Welcome to Doc to Doc podcast. My name is Abbas Shafi, gastroenterologist.
And I'm Rob Hoyer, medical oncologist.
This is a podcast about lifestyle medicine, disease prevention, and longevity.
This podcast is provided for informational purposes only. It is not medical advice. Please consult your physician for individualized therapies. Hi, everybody. Welcome to today's podcast. We're going to talk about new diagnostic tools. And so we're going to do an overview of several different diagnostic tools in no particular order. And common theme is that all these tools are available either through your physician or can be ordered from your home through the internet, or there's a variety of companies. And we'll talk about some of them. So the first topic we'd like to cover is the biological age clocks. And this is something we talked a little bit about in an earlier episode. And these are really important in that it lets us measure the what's called the biological age, and you can actually figure out your biological age relative to chronologic age, or the actual day you were born. And this is important because it actually lets us measure what we're doing, whether it be lifestyle or other interventions. There will be pharmacologic strategies, medications available in the coming years that will be used to treat aging. And so these will be really important to actually measure the effect of these interventions. So how this works is this was about 10 years ago. It was recognized that there are these what's called these CG repeats in the genome, and these are these repeats of C and G, these called these islands of these, and there is what's called methylation. And what happens is when a gene is turned off, it gets methylated. And so this is part of what's called the epigenetics of how our genes are expressed. So this is the turning on and turning off of genes throughout development. And as we go from a child into adulthood, different genes are expressed, turned on or turned off. And so it was found that there's a few hundred of these they're called CPG islands that are expressed either or not, either methylated or not. And by looking at the pattern through sequencing of these, you can find out, estimate the age of an individual. And it's actually really quite accurate. Within 3 years, you can typically estimate the age of an individual with these techniques. And so you can also do different tissues. And so the tissue could be a blood sample, it could be a skin sample, it could be saliva, and there's different results. So different tissues in our body can age at different rates. And so that's also kind of interesting. You can have different types of testing. And also the testing has come down in price dramatically. So there's a couple different companies that do this. There's one called Inside Tracker is one of them. And you can get your biological age by sending in a sample for a couple $100. They also do some other metabolic tests and whatnot. And I should note that these companies that we're mentioning, we're not promoting, we're not paid to represent these companies. We're just simply mentioning that they're in existence, and they're something that you can check out on your own. So these techniques are now available, and what's happening is that the prices come down so much that this will allow calculation of the age on a very frequent basis. So eventually we can do it. Now we can pretty much do it yearly for a couple $100, but maybe in the future we'll be doing it monthly or even weekly or even more frequently. So you can really assess the impact of a intervention, whether that be exercise or diet or meditation, or if you're having a stressful period, you can really look at what's happening. So this is one of many different techniques that's going to be utilized as we move forward into this new era of treating aging as a disease. So lots there, but if you have any questions about this, please feel free to chime in. You can always ask a question through the podcast link, and we're happy to answer that.
It is great to know that the technology can show us and help us to not only see the patient how taking care of themselves and be able to have a litmus test or measuring technology to do that. As you see, we see many patients that sometimes you look much younger than state of their age, and the other ones, based on their lifestyle, looks much older. And it is, of course, taking care of yourself by eating right, stress management we have mentioned before, and preventing the toxins, smoking, alcohol, so the lifestyle, and you see that we can guess game it on an individual patient by just doing the lab data, their vital signs. But it's good to have a technology that can help us to see how much a person chronologically age, as well as biologically, to be able to have maybe a point of interest, like as we do exercise, get our heart rate certain or keep our weight down. So I think this is a fantastic future, and I think this is just the beginning of this new technologies.
So a couple interesting points. So this this biological aging analysis, that these clocks have been looked at for different individuals. So for smokers, usually have a much higher rate of aging. Also, I was looking, as part of this preparation for this podcast, looking at patients receiving chemotherapy. And one of the things that we've seen for a long time with chemotherapy is patients often will have, after they have chemotherapy, their skin changes, their hair turns gray after chemotherapy. And so this was a study that looked at before chemotherapy and after chemotherapy for breast cancer, and there was a increased biological aging with the chemotherapy. So it's kind of interesting. Also, interesting, radiation seems to play a role as well, and radiation seems to also contribute to aging too. How that works, we're not quite sure, because we're not radiating the whole body; we're radiating one area of the body.
I think it's the body inflammatory response to any of the things. Is there, of course, the sort of toxin that we do to kill the cancer bad effects all over the body. We see from mucositis to diarrhea to nausea, vomiting. As we kill the cancer cells, we see effect of the normal cell, and I'm sure the consequence of this and recovery for that will slow down our process or decrease our longevity. But this is a fantastic thing to be able to look and hopefully you have more clear data for each therapy. What is not only we can calculate by the data, but also be able to measure what are the possible effect on the longevity of a patient.
I think that's been a criticism of lifestyle medicine. The whole area for many years is, how do you measure this? And
which is very difficult.
And so this hopefully will give. I'm quite confident this will give us a tool that we can use. There'll probably be other tools too, and of course all the typical other biomarkers, blood pressure, heart rate variability, all the cholesterol, glucose, all these other hemoglobin A1C, which is an average level of glucose. All these other things will be important, but yeah.
There's also been the same paradox or conversation between traditional medicine versus modern medicine. When I was in China, many of the traditional medicine says, we know it works, but I cannot tell you how it works.
Yeah.
But because my father, my grandfather, or my teacher says this herb works, but of course, in modern medicine, we can more calculate or know the bio availability or pharmacology of each tablets. So we have more data. So it's good to sort of narrow the gap and have some measurement of what effect on us, whether it be our lifestyle or whether improving with exercise, better dieting, or to be able to put it together. It says, hey, if you don't smoke and don't take care of yourself, you don't do this, this will decrease your lifespan. So these are very good tools, I think, for each individual who was interested. Again, these are the new technology. Again, we're not promoting this there, but these are just the new horizon. And another thing is to detect early cancers. So that's a new technology that, as we both know, the earlier we can diagnose the cancer, the better outcome, the better longevity. And you probably can tell more about it, the ctDNA.
Yep. So this is something that we've been using in the clinic now for a couple of years, and really came out of nowhere. All of a sudden, we had these reps coming in talking about you can do these blood tests and find out the markers for your patient's cancer. And it's kind of interesting story. It was back in the 1990s, actually. This was first identified in pregnant moms who there was in the free floating in their bloodstream was DNA from the baby. And so this was something that was identified early on, and typically it's these short little pieces of DNA. So it's not the whole chain of DNA. DNA is typically a very long molecule. This is like 160-ish base pairs, so real short little segments of DNA floating around in the bloodstream. And over the last 30 years, there's been a huge effort to try to figure out what to do with this information. So initially it was used for detection of fetal anomalies. That was an initial use of this technology. But then it moved into the space where patients with cancer, often the tumor seems to, for reasons we don't fully quite understand, it seems to shed this DNA out of the tumor. And my thought is it's probably what's called the process of what's called apoptosis, where the immune system is attacking the tumor, causing programmed cell death, which is called apoptosis. And then you're getting the little pieces of DNA that are remnant from that, and those are floating around in the bloodstream. So it turns out you can actually detect those, and then you can actually go and you can sequence them to figure out what's in there. So where we're using this technology today, where this is something we do every day now in the oncology clinic, is we can have a patient come in and get a blood sample, and we can find out if there are markers for treatment based on that information. So currently we still have to do a tissue biopsy to diagnose the cancer, but if there's not enough tissue with that biopsy, we can get these marker studies. For example, a patient with what's called EGFR mutated lung cancer, which is highly treatable with an oral medication. We can do the mutation testing on the tissue sample, but we can also do it in the bloodstream. And really the neat thing is sometimes if a patient's receiving treatment, they'll get resistance. Resistance mutation appears in the tumor, and we can pick it up in the blood. So you don't have to resample the tumor. You can actually do a blood test and find the information. So it is fascinating, really interesting.
And this technology called circulating DNA. And I think again this is like the biological cloning just gonna be more advanced. So we probably, if somebody has certain symptoms or family history, be able to detect periodic early cancer, even that we cannot see by CT scan or MRI or before patient have any symptoms. So this is a fascinating, I think, new frontier on oncology and on medicine as well.
Yeah, this is I reviewed some of the literature, and a lot of this comes from for cancer detection. Early cancer detection comes from a company called Grail, and this company has looked at patients with cancer to determine the markers that are in their bloodstream when on this circulating tumor DNA test. And so the test just became commercially available at the end of 2021. It's not covered by insurance currently. I think it costs about $900 and involves sending in a blood sample. And then the company quotes about a 50% sensitivity for detecting cancer. One part about that that's kind of interesting is more aggressive cancers are more likely to be detected. So these are things like pancreas cancer, lung cancer. These are the more aggressive
That they have
types
more
of cancer.
faster turnovers and
They probably
mutation.
shed more DNA. Things that probably can't be detected are like brain tumors are almost impossible to find on this with this technology. So that's
sarcomas.
some of the sarcomas may or may not be detectable depending on the rate of growth. So early stage 1 tumors are less likely to be detected. Stage 2 or 3 are more likely. So that goes along with just the more circulating tumor DNA there is, the more likely you'll get a positive. So the key thing about this test, which is kind of interesting, it's about a 50% chance or sensitivity of picking up a cancer if present, but it's got about a 99% specificity. So that means if the test is positive, there probably is a cancer somewhere in your body, which is kind of interesting. So if that test is positive, the next process is to go ahead and do cancer screening scans to try to figure out what's going on. I think this technology, it's helpful currently. It's not clear how it will be used in primary care, how insurance, if insurance will reimburse, the price will probably come down over time. It'll probably get better, I suspect. I'm hoping it can be added to the whole cancer screening armamentarium that we have currently. Because right now we screen for just a few types of cancer. There's many that we don't. I think everyone pretty much knows somebody or a family member who
has rare cancer,
just has cancer and had no idea, and it was all over their body.
By the time diagnosed, yeah.
Right.
Well, the new topic we can talk even put this is the whole body MRI, and seems like it's very more getting gigs in Asia than in the United States, but is another one to very interesting to talk about that. Instead of today, when, for example, we have somebody has blood in stool, we do colonoscopy, then from colonoscopy we do a CAT scan, and from CAT scan we do a PET scan, and PET scan, to stage, then we have to do the blood tumor markers and there. So I believe that in Korea they were doing the total body MRI to detect not only cancer and other type of inflammatory process. So I think that's another new thing on the horizon. Whether you get certain age, do this total body MRI to see what's going on in your body. Of course, it's costly, expensive, but again, the future of medicine is just is early detection and with better prognosis. I mean, I remember that when from fax machine to computer, slow computer, to then email, then to texting, and today's media, we have for past 20 years we have come a long way in our communication, and I think the same thing happening in medicine. So again, we will not promoting this thing. You guys go get it. Just want to know that with all the tools that we have, there's some newer tools in horizon that I think will be helpful. Do you want to make some comment on this whole body MRI, Rob?
Yeah, and so this is an emerging technology. It's not all the MRI centers have the proper coil, which is how MRI works. You have to have the proper coil to do this type of MRI scan. But it's what it looks at is just what it says. It's a MRI usually of the brain and then the body, looking for any type of abnormality, and it could be cancer or something else. For example, a brain aneurysm or
stenosis in the spinal cord, arthritis, or
cardiovascular disease.
Nodule in thyroid.
Yep.
And others. But yes.
So always the challenge with these types of techniques is the false positives and what you do with the incidental findings, what we call them, incidental lomas, we call them. But in an era we're moving into more data and just having knowledge about these things so we can do something about it, or if it may be a minor finding, observe it, recheck it again in a year, for example. So there are a lot of nuances to this, but what's being found is that in a certain percentage of these individuals, depending on the intensity of the testing and whether you include cardiovascular scans, brain MRI, anywhere from 5-10% of individuals who go through this testing will have something found. So that's so 1 in 10. That's kind of interesting that 1 in 10 have some type of clinically actionable finding. And so
that can be hopefully curable or
right.
or fixable
exactly.
Yeah.
So it definitely needs more research, but and clearly it's going to be something that I'm sure insurance will not cover for probably quite a long time. But as the cost of imaging decreases, there are some really interesting new techniques, and maybe we'll talk about that in a future podcast about new imaging techniques that are going to lower the cost of imaging. If you can lower the cost of imaging, then all of a sudden this becomes widely available to everybody.
But if you look at the piecemeal that we do today, we do an ultrasound or we do CT scan, then we do the PET scan, and all of those with radiation involved and all of that. So maybe it's better to do one, especially with certain cancers, if you know that there's a metastatic cancer somewhere, to do one test and be able to do not need to do biopsy or do not do any further investigation based on that, and look at the prognosis and the treatment. So yeah, it's a fascinating world. In GI, of course, with the invention of endoscopy in 1970s and earliest 80s, we have come a long way. Initially with very, very stiff scopes, whether to do just a proctoscopy or just limited to the esophagus, has evolved to much more better scope, better detection for polyps and cancer and stomach ulcers, and with the new medicine also has increased the longevity. In just looking at the stomach for peptic ulcer disease, you have reduced the surgery by over 98%. So with the better medication and all of that, and further looking at more in depth the capsule endoscopy, which is the size of a vitamin, fascinating technology that has now camera both sides that lights up and transmit data to outside of the body to a box, and pretty soon going to be probably more technology, more we can just get in the computer probably through the Wi-Fi, and that can detect very early cancer in small intestine, esophagus, look at for inflammatory such as mild Crohn's, anemia, or obscure bleeding that people come with recurrent anemia. So the technology in GI has evolved as well, and when we diagnose someone, another technology mixing the ultrasound and endoscopy, call it endoscopic ultrasound, can tell us, for example, pancreatic cancer or esophageal cancer or rectal cancer, how deep is the cancer it is, and maybe prevent from going to under surgery, and that by itself can change people's lifestyle. It's tough to a patient go to a huge surgery and end up have recurrent disease, and not only the disease, then you have to deal with the complication of the surgery. So through the endoscopic ultrasound, not only we can detect smaller lymph nodes near the GI tract, or 10 centimeters or so, also we can sample them to the what they call FNA, fine needle aspiration, or by different by just the look at them to see whether these are malignant or not. So yeah, the technology has come a long way, not only in cancer and GI, and I think our time not allowed to do in the whole medicine, from neurosurgery to cardiology to many other aspects of the medicine. This technology, robotic with technology with surgery and prostate surgery, those are all evolving in a very fast pace, and hopefully with this all new technology, we will have a better prognosis for the patient and early detection.
I was nodding my head the whole time because I completely agree, and that's the medical imaging has come a long way. I remember as a medical student having to go into the film room,
put
get
films
the films and put them up on the light box, and then we're trying to squint at these little tiny CAT scan images. But now we have these available in the room with the patient. We can pull up the scan and make it really big on a screen, and the quality of the images is also dramatically improved, both for MRI and for CAT scan. CAT scans been around for years now, probably since the late 60s, early 70s, and we've had just 50 plus years of CAT scan. It's just incredible the quality of the images we get with just a routine order for a CAT scan. So this is definitely more to come on medical imaging, but certainly something that I think the better we can look inside the body, as Abbas mentioned, the less we have to do invasive surgeries or biopsies, now we can also do needle biopsies, which are really handy and often don't have to do any open surgical procedures to make a diagnosis, which is great.
I think that was a fantastic overview of at least what's in the horizon in technology and medicine. Again, we're not promoting any company, or we're not asking you to go to ask your doctor to do these tests. You just can discuss with your physician or oncologist to whether this is appropriate for you. And it just as we get all the negative news in today's, there's some positive. The technology, as anything else, is good, can be good depending on how you use it. As long as you put not the profit ahead of the technology, or you don't use that as a profitability. I think that's early detection and longevity is what we're all looking for, longer, healthier life.
And I agree. Technology is a tool. It's really agnostic in terms of it being good or bad. It's just a tool, and we have to figure out how to utilize those tools. And I think that's really the story of medicine over the past 100 years, is trying to figure out how to utilize the new technology, but also how to move it much more quickly from the lab to the patient. And that's, currently, or up until now, it's many years, sometimes 10, 15 or more years to have something from the lab really impact medicine in the clinic. And so how do we compress that down to a couple of years or even less? That's, especially for big discoveries. I think as we can start measuring the impact of these technologies, we can really start to move them more quickly. We can actually see real time how they're improving patients' lives and move them more quickly. Of course, where we have the evidence. I think it's important to note that some of these things we're talking about are so new. We're still collecting data, but that's the beauty of this. The practice of medicine is it can change literally every day, and we're having so much medical knowledge now. It's just it's like a fire hose. Trying to just digest it all is literally impossible. So we try to do the best we can, stay up to date, and keep asking questions. Yeah,
one thing that it was really impressive when I did the medical mission in Philippines. One of our physician brought an ultrasound probe that you could read on your iPad or an iPhone. And that helps so much to where there's almost zero technology. There's nothing around. Even the basic laboratory you cannot do. So you have to operate based on just, I'm saying guess game, but based on your physical knowledge and physical exam and history and of course most of the things that we diagnose is late stages. By having this small technology, we could easily pick up the gallstones, the cyst, or cancer, or thyroid nodules, and that helps for patient to be properly diagnosed, as well as whether this surgery can help the patient or just send it to the center that they can. So yeah, they're getting smaller, they're getting better, and I think they're going to be great help in the future of medicine.
So last but not least, we'd be remiss if we didn't mention wearables. And so this is a huge area, and I think one of the biggest areas where there are all sorts of wearables right now. You could argue that our cell phones are kind of the primitive wearables. Then you have the different watches and things of that nature that can measure heart rate variability, EKG. The next level is measuring blood pressure with a watch. And that's coming. It's actually available now, and it's actually
Stanford University just had
yep.
a program on that.
Yep,
Yeah.
yep. And then you have all the invasive monitoring. So I'm actually wearing one right now. It's called the continuous glucose monitor, and so this will measure glucose continuously. And folks don't realize that back 30, 40 years ago, to measure the blood glucose was a huge deal. This was not something that you needed a massive machine, you needed a special lab, a fresh blood sample from the patient, and it was very expensive. And that was how diabetics were diagnosed and then treated, to see that when they were treated with insulin, their blood glucose came down. But now, for about $100, you can get this little disc. You put it on the skin, and it measures glucose continuously for 14 days, and you can scan it with your phone, and you just scan the glucose, and so you can see the effect of a meal. And interestingly, what I've found really fascinating is the order of how you eat the food affects the blood sugar. I was just fascinated by this. If you eat the protein, at least for me, and this may not be the same for everyone, but there's some trends. If you eat the protein first, oftentimes have less of a glucose spike.
Mm-hmm.
And so this is something that you can just experiment with different foods. Try rice, try potato, try your favorite breakfast cereal, whatever, and see how it affects. You can eat a orange, then you can drink an equivalent amount of orange juice and see how that affects your blood sugar. You can do all these little experiments on yourself. And I just have a great time with this. And the reason this is important is the more variable the glucose, the more it's been shown to be associated with aging. And so you want to keep your blood glucose as steady as possible. You don't want big spikes
or downs.
You want to keep it stable. And so this is something that individuals can do. And so there's a variety of companies that are doing this continuous glucose monitoring. It's inexpensive. It doesn't hurt to put it on. There's a little baby needle in the applicator, but the needle goes away, and just a little cannula sitting in your subcutaneous tissue of your arm, and it works great. So, yeah. So and this is one variable now where glucose are measuring, but what if we can measure 5, 10, 50 variables? And so this is coming over the next few years. We'll be able to measure probably hundreds of things,
cholesterol,
simultaneously,
your electrolytes, and, and other things
everything
to see what, when you're eating a burger and fries, see what happens to your body. And maybe that shows people how to take care of themselves.
Exactly.
It's good to you can preach to people about certain things, but it's good to see some actual data to prove it. So this is another fascinating new technology, and the way we look at the society, I think within next 5 to 10 years, going to be like 50% of the population going to have diabetes. So if the people, they know ahead of times what causes this variable in their sugar, maybe they adjust their diet. This, as you said, between a soda or an orange juice versus eating real fruits, to see what are the variability and affect your body, then you maybe think twice to do that over and over.
Yep, I completely agree. I think it's going to be, a lot of these are developing that we call the UI, the user interface, and essentially we'll have a UI for our body and be able to have recommendations for certain foods or other medications for treating certain conditions before they become clinically evident, which I think is really interesting. You can actually pre-treat a lot of these conditions before they happen, and whether that be with lifestyle, maybe a medication for a short time to get things on track, and then you can stop the medicine and whatnot. There's a lot happening here, and so I really consider this that's like a second renaissance of, and the first renaissance was with art and technology, but we're in this renaissance now of the information age, and is such a fascinating convergence of all these things coming together. And these are not individual technologies, but they're convergent, and they build on each other.
And that's the same thing has happened due to COVID in telemedicine.
Yep.
For many years that many people in the periphery, they could not see a doctor, or they had a family member or be able to make an appointment to go to a big medical center. So today, with the COVID has really boosted a lot I'm sure in your practice and my practice. You can easily, if you have a cell phone or computer, you can sit down where they talk to your physician. At the same time, he can look at the labs, he can show you the labs, he can show you the technology. And I find out, particularly for disabled or elderly people, prevent them from getting, out of the house or getting, getting infection, and they feel a little more. I find that they feel more comfortable at their home than coming to a doctor's office. They're more honest, they're more relaxed, and also the family can sit down with on a conversation. If they're fabbing or they don't want you to know something, the family can interfere with that. So I think this is, for past 20-30 years, the medicine want to have the telemedicine, but has really past couple of years had a whole different speed on it, and I think gonna stay for a long time. Not only, I think, for big cities, you can communicate with patient in a remote area when they have a problem from their mobile home. I talk to, and they can be surrounding small towns here in Colorado or other places that they really do not have access or save the gas or spending the night in a hotel to come see us. You can easily have a conversation with them, and that's it is I think for me has been really initially I was not sure how it's gonna work, but I think it has really my outcome to this, I think, is gonna be great. Not for here. I talk to people across the world in this way now. People back home, I had yesterday somebody call and that, they email their scans and stuff like that. Just from humanitarian point of view, just get an opinion, which takes them a plane ride, visas, and all of that, and you can have an honest conversation with them. So I think the telemedicine has really, again, is a new technology, and I think going to improve a lot in our future.
So I do a clinic in rural Colorado for oncology. So I go there every month for 4 to 5 days. And for years, we tried to get a telemedicine solution, but the problem was insurance, particularly the Medicare, didn't cover telemedicine. And so come COVID, though, everything changed. And so this is something that telemedicine is something that I think really can help improve access. And there is still a time and place for in-person visits. Absolutely.
There's nothing to replace that.
Nothing to replace that.
So.
But having that option, or for example, a quick check-in saying so we started new medicine. How did it go? It's been 2 weeks. How are you feeling? What side effects are you having? A lot of times in oncology, we're starting an oral chemotherapy medication. It's great to have a check-in visit. Otherwise, the patient would have to drive, 3 hours each way for a visit that might last 15 minutes. And so it's a hugely helpful. What we find in some of the rural areas, especially in Colorado, I'm sure this is similar elsewhere, I imagine, is that internet access is not so common. And so that's something that
hopefully to improve.
It will improve, I'm sure. And so now we're getting these big satellite webs of low Earth orbit satellites that are going to be out there, and all these things, Starlink, and Amazon has one, and there's a variety of different companies doing this. Virgin Galactic's doing one. And so these are going to be helpful to provide internet into these areas that currently have very low speed internet. So we'll be moving, they'll be leapfrogging into a very, very fast internet to do this video call.
And especially with oncology people, when you're neutropenic, which means they don't have their defense mechanism is very low. When they get out of the home, they're prone to get infection, and so that really helps those people communicate and whether with the nurse, whether with the office, or whether with the physician, to have this 10-15 minutes visit, and saves them lots of headache and particularly infection and other type of things.
Yeah, for the U.S. healthcare system, access is very much concentrated in the urban areas and suburban areas, and so this is a great way to have equity of access to healthcare. And so again, it doesn't replace the in-person visits, but it is really helpful to have that, whether it be an initial consult or a follow-up visit, just to have that conversation
and expedite the care, because
absolutely,
as you said, in many rural area they do have a CAT scanner, or they have certain tests we can do. It's just basic blood work, instead of driving 4 hours coming here, and then you have to put the order, then I have to go back there, so then you have to do that, and then I come get this report, and you cannot see it. Now today, I think that has at least helped me a lot with rural area, and probably with you even more. So that's another technology we are hoping to improve and get better access to patient for early detection and diagnosis and treatment. Well, I think this was a good introduction to modern technology and new horizon for medicine, particularly in GI and oncology. So we're not, again, sponsoring any company. We just want to make our audience to be aware of the new things coming, and hopefully all for the better than bad. So this was just a brief introduction, and hopefully in a few months we can have a more update, more and answer some of the questions that the audience may have. So until next time, I'll say goodbye.
And thanks everyone for listening. And please, we'd love to hear your feedback. And if you have a few minutes, drop us a review. I'm just going to do a short plug for my newsletter. So this comes out every few weeks, ideally monthly. I do a brief newsletter, it's called Exponential Health Span on Substack, and it talks about a lot of the topics, and it also, I get into some of these. I'm very interested in technologies that can help individuals and families to live better, healthier lives. And so we talk about Bitcoin, we talk about all sorts of new things in there. So love to have you join that and send and hear your feedback from that as well. So until next time, thanks, and we'll talk again soon.